Good morning. This is Chris Neal. I'm an interventional neuroradiologist, neurointerventional surgeon at Doctors Medical Center, and my specialty is stroke and vascular disease of the brain. I'm about to take you for a walk in my shoes and have some idea of what this specialty is about and how we treat and deal with clinical challenges in neurovascular disorders from an interventional standpoint. The slideshow before I started has got two types of slides. Some are as the one you see on the screen with the sequoias in the background. These are cases done here. Some of them with ocean in the background are from my prior practice on Maui, just so you can tell where things were done without asking. So to begin, this is a team sport. This is a mix of my angiography team and nursing staff from the neuro ICU. And this is by no means the entire group, but it's a representative cohort. So the kinds of diseases and things we manage require a team effort. These are not just the work of the surgeon at the table. Stroke, scope of problem. It's the fifth leading cause of death in the United States, with over 140,000 Americans dying every year from a stroke. It's the number one cause of serious long-term disability. Every 40 seconds in the USA, someone experiences a stroke, and every year, 800,000 Americans experience a new or recurrent stroke. It has a disproportionate effect on women. It's the third leading cause of adult death for women. Each year, 55,000 more women have a stroke than men. In general, women live longer than men, but 1 in 5 women will have a stroke. Among women under the age of 45, brain attack or stroke is more common than heart attack. And perhaps most pointedly, every year stroke kills twice as many women as breast cancer. We have lots of screening programs for breast cancer. There are no good, dedicated, viable screening programs for stroke. I'm going to refer back to some images taken and presentation from David Sakamoto from the state of Hawaii very briefly. These are the causes of death in the islands. Stroke is 21% in the state of Hawaii. This is a graph that represents by county, and actually Maui County is just an island, the death rate and stroke rate for mortality rate for the 4 counties, and you'll see that the stroke center we built on the island of Maui has a long-term stroke and death rate much lower than the rest of the state for the 11 years that the state kept these metrics and I ran the program. So how do we do these procedures? So they're done with a catheter. Our access is usually in the femoral artery. Today you'll hear people using the radial artery, but it doesn't work as well for acute stroke intervention as it does for some cardiology procedures. So access to the femoral artery, and the catheter goes up to the aorta and then up one of the carotids of the vertebrals and then ultimately into the brain. It's a tapered system, so the initial access is with a larger catheter, 5 to 8 French, and then a microcatheter, 3 to 1.9 French, micro wires, 0.18 to 0.09. This is a cartoon where you can see the guide catheter in the neck and a microcatheter out into the brain and coils in an aneurysm from the catheter tip. This is actually our arteriography suite here at biplane room at Doctors Medical Center in Modesto. So there are 2 major types of strokes. I borrowed these images from Stanford Stroke Center many years ago, but they still are great representations. One is intrinsic thrombosis, where you have underlying plaque in the vessel, and the plaque ruptures or becomes sticky, and there's in situ thrombosis. Then the posterior circulation is often thrombotic. You certainly can have emboli in both locations. In the anterior circulation, we tend to see a lot of embolic strokes where the clot came from elsewhere, typically in the heart or the aortic arch. So we're going to run through a few studies. We have a 70-year-old with an NIH of 22 with acute loss of consciousness, right hemiparesis, gave deviation, visual field deficit, aphasia, and neglect. Her last known well was within the IV thrombolytic window. She was treated with intravenous thrombolytics and transferred to DMC for intervention. Head CT on arrival is normal. So initial arteriogram documents a carotid T lesion. On the lateral, you can see the posterior cerebral artery arising from the anterior circulation. This is a persistent fetal origin and not unusual, normal variant. The carotid itself is occluded, and there's no flow in the middle or anterior cerebral arteries. This is called a T lesion. The entire hemisphere is at risk. Most critical is the internal capsule. Following initial thrombectomy with aspiration, you can see now the carotid is open. There is some flow in the anterior cerebral artery, but the middle cerebral artery territory still is underperfused. There's thrombus here in the distal M1 segment with only a little bit of contrast getting past it. So here we have a second aspiration. This is a road map, so we can actually see where we're driving, and a catheter has been placed out where the clot is. And this is after final thrombectomy. Now the entire candelabra is back and the entire hemisphere is getting perfused. So let's look at the temporal characteristics with this case. The patient was last known well at 1 o'clock, received IV thrombolytics at 15:13, arrived in our ED at 16:01. Puncture time was at 16:34. This is the clot that was removed. And reperfusion time 16:55. CT scan the next day shows a normal head CT, and she was discharged home in excellent condition. So we're going to go back and review this slide, because the next case I'm going to show you is a situation where we have in situ thrombosis and an embolus at the same time. So this is a 73-year-old male with an NIH of only 7 with facial paresis, left-sided paresis, and dysarthria. Last known well 7 hours prior to arrival to the Doctors Medical Center Stroke Center. CT perfusion imaging shows no completed infarct on the cerebral blood flow. The green area is what will stroke if we don't treat this patient. This is a fairly large area, 60 cc's with an infinite mismatch. So on the CTA, you can see the internal carotid on the left, and the internal carotid on the right is absent. There's a thrombotic occlusion of the internal carotid origin. And if you look up in the intracranially, you can see the middle cerebral artery on the left, and on the right there's an M1 segment occlusion of the middle cerebral artery. So we have an in situ thrombosis of the right internal carotid at the origin, and an embolus to the M1 segment on the right. So here's the initial carotid arteriogram. My guide catheter is here. Here's the stump of the internal carotid, which is completely occluded. The vessels you are seeing are the external carotid branches. This is a road map image again with a balloon across the occluded side. I managed to get a wire safely and easily to pass across the occlusion. This is after angioplasty. Although it doesn't look perfect, there's clearly flow that's been restored in the internal carotid artery. And now when we look up inside the brain, you can see an obvious M1 occlusion with some proximal lenticulostriate perfusion. This is a few minutes later after mechanical thrombectomy, and the middle cerebral artery has been reopened. There's a persistent M2 occlusion. The stump is right here. You cannot appreciate that on the frontal view. This is after a second pass. You can see the microcatheter here in that occluded segment, and now the entire candelabra is open. This is the clot that was removed. The large one came from the carotid itself, and the smaller one came from the middle cerebral artery. Wake-up stroke. This is an 83-year-old with atrial fibrillation, last known well the prior evening. Stroke symptoms on waking up with an NIH score of 12. Significant for visual field cut, right hemiplegia, and aphasia. CT scan's fairly unimpressive. So the perfusion study shows an area of altered cerebral blood flow of about 16 cc's, likely representative of a completed infarct, although we don't see that on the head CT, but an enormous area at risk for an ischemic event involving the entire left hemisphere. This mismatch ratio of 10 is unusually high. Rarely do we see them over 3 or 4. The total volume is nearly the entire hemisphere. So here's the initial carotid arteriogram. You can see the M1 is occluded proximally. Here we have an aspiration catheter with a microcatheter through it at the site of occlusion. This is a few minutes later. And day 2 is an NIH score of 0. The head CT is normal. And the stroke that we actually thought was perceived on the cerebral blood flow doesn't really pan out. So perfusion imaging is not an exact science. There are times we'll see a perfusion scan where it looks like there's a stroke and there isn't, and the reverse is also unfortunately true. Time to rescue. Time is critical. This is an 81-year-old. Last known well at 7:30 in the evening, found down at 8 o'clock. History of AFib, hyperlipidemia, prior stroke. Her NIH score was 17 at the outside institution. She had left hemiparis, aphasia, gaze deviation. They couldn't give thrombolytics, so she was transferred from a hospital about an hour away. Didn't arrive here, however, until 40 minutes after midnight. Her NIH score at that time was 33. So her CT at the outside facility shows well preserved. If you look, gray white matter junction here on this side, there's a thin ribbon in the cortex. You're already losing it in most of this hemisphere. This is at 2113. So by the time she arrived here, her perfusion scan at like 2 in the morning or 1 o'clock in the morning shows a completed infarct that's in the entire hemisphere, crossing over somewhat into the middle cranial fossa and probably some of the anterior frontal lobe on the left. The ischemic area also looks enormous. So her mismatch volume is 106, with a damaged area of potentially 300 and a ratio less than 1.8. With such a high NIH score and an extensive infarct, it was felt that endovascular rescue was not warranted, and there was not much I could do. I actually came in and chatted with the family and explained to them if this were my wife or sister, I would not want to treat her. She would not likely make a functional recovery. You can see there's a significant amount of damage already in the contralateral hemisphere. This is a 93-year-old transferred from another institution with acute onset of right hemispheric ischemia and a CTA suggesting an occluded right internal carotid at the origin. This is a horrible type 3 arch. There's a twin lead pacemaker. You can see my catheter is in the innominate artery, and the right internal carotid comes up, comes straight at us, then does another S. So there's actually a triple S here before it heads up to the internal carotid. I could not negotiate this with a wire. So utilizing this image as a roadmap and template, I used ultrasound. CT perfusion scan shows the entire hemisphere risk with a small stroke. Large mismatch ratio. Used ultrasound to do a direct carotid puncture. So we put the guide sheath directly into the internal carotid artery, took it right to the origin of the occlusion, and single pass aspiration within about 15-20 minutes removed this large amount of thrombus. You can see it's down in the aspiration container. And 24 hours later, this 93-year-old still has a normal looking head CT and went home neurologically intact. I'm going to chat for a minute about true cerebral ischemia, which is relatively rare. I don't see many cases here in Central California. This is a 63-year-old with difficulty speaking or being understanding being spoken to, with right-sided weakness and neglect. The internal carotid artery in the lateral projection shows a high-grade critical stenosis in the vertical petrous segment. So The skull base you can see is right here. So this is inside of bone. There's no way to get up in here. This is inside a bony canal. And then the siphon terminates on top. This is a dime, which is exactly 18 millimeters. It's an older image. The focal stenosis is down to less than 0.5 millimeters. My imaging measurements on this older equipment are far less than optimal. And there is preferential filling of the external carotid. So when contrast is injected, it's actually refluxed back out the external carotid rather than flow into the internal carotid because of this high-grade stenosis. So I hit this with an angioplasty balloon, took it up to 2.5 millimeters. It doesn't look perfect, but it's far better than it was. And if you look at the pre and post image, look at the density of contrast both above and below the lesion, and the patient did well. This is one of my favorite cases when I first started doing neuroendovascular neurointerventional radiology. This is back in '97. This is a 34-year-old who was a lay stringer back then, with chronic shortness of breath and new onset of headaches. Her room air blood gas was 77. Of significant note, she's had 2 pregnancies, both of which were uneventful. The salient finding on the coronal T2 brain MR are the 2 embolic strokes in the cerebellum. Here's her chest x-ray, which at first glance appears unremarkable. This is just a reflection from my then out-of-date camera, now out-of-date camera. There's a serpiginous density in the right upper lobe, which isn't well characterized here. Here's the CAT scan, and you can see there's a large arterial venous fistula in the lung. This is hereditary hemorrhagic telangiectasia, or Osler-Riverindu disease. Here's her pulmonary angiogram. So I brought a catheter up from the groin in the femoral vein through the heart and out into the pulmonary artery, and you can see this large AV fistula. So what's actually happening is the filter in the lungs is being bypassed by this fistula. Many of these people die from intracranial abscesses from just bacteria from their teeth going through this and straight to the brain. So I put a catheter, again, up through the heart, out into the arterial venous fistula, and coiled it off with large coils until it was gone. This is the follow-up arteriogram. You can see that it's thrombosed. There's no flow going through it any longer. She actually had 4 of these. This is the one we just treated. I had to do these in stages. There was a second one up here and a pair of them down on the right lower lobe. I've actually followed her for the better part of 20 years, and she's done fine and had no sequelae. I show that case to remind the uninitiated that coils used for treating cerebrovascular disease aren't always put directly into the brain. Cerebrovascular ischemia is disease of small vessels that are arteries and creates infarcts, and it represents the vast majority of minor strokes. The cumulative effect of serial or multiple minor strokes may be devastating. There's an entire myriad of pathological processes with one final common pathway, which is microthrombosis of very tiny arterioles. These are not venous. Examples include systemic lupus erythematosus, cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy, mitochondrial encephalopathy with lactic acidosis and stroke-like episodes, primary CNS arteritis, hypertension, lacunes. Post-reversible leukoencephalopathy and moyamoya are differing pathology we'll address later. This is a 30-year-old with frequent stroke-like symptoms. You can see on this MR there's a patchy areas of abnormal signal in the corona radiata and centrum semivalley bilaterally. There's an incidental cavum septum pellucidum at Verkey in the central ventricular system, normal. Sometimes things that appear to be strokes aren't. So this is a 58-year-old patient that was transferred from the Big Island with lower extremity dysfunction on the left and headache and stroke-like symptoms. At that institution, they thought she was having an anterior sublunar artery infarct, but on close evaluation, you'll notice that this abnormal signal crosses in the posterior callosum, both anteriorly and posteriorly, and strokes don't generally do that. So I obtained a NMR spectroscopy, which looks at the metabolic tissue of the brain and its function. So this is normal brain tissue, and you'll see that N-acetyl aspartate, which is a normal component of brain tissue, is very high, and creatine and choline, which are indicators of anaerobic metabolism, are relatively tempered, and the lipid and lactate profiles are very low. Conversely, the area of interest now represented by this box shows a completely different spectrograph. Choline is off the chart. Creatine is fairly similar. There is no normal brain tissue. The NAA peak is absent, and the lipid and lactate peaks suggest progressive or rapid, highly metabolic states. So these three indicators, the absence of brain tissue with a highly metabolic process, can only really be one thing, and that's a tumor. This turned out to be a grade 3 astrocytoma, which I biopsied the next day. Venous infarcts, they are rare. They're usually due to underlying hypercoagulable disorders or blood dyscrasias. They may be due to acquired or congenital vascular malformations. I should also mention they are occasionally seen in infectious etiologies. AVMs, dural AVFs, cavernous fistulas may contribute. This is a 51-year-old that I saw as an outpatient with blurred vision and severe headache. The T1 weighted images with gadolinium on the left show this passive venous congestion. You notice there isn't any high signal in the rest of the brain. And the T2 weighted image shows edema in the subcortical white matter in the occipital lobe on the left. Coronal images confirm the same pair of findings. You can see there's this venous congestion and on two different sequences. So this is her digital subtraction arteriogram. Here's the internal carotid artery and lateral projection. Here again we have a persistent fetal origin like the first case I showed you today, arising from the internal carotid artery. But what's unusual is we're still in the arterial phase of the image and you're seeing the sigmoid sinus opacify. So there's a small branch distally that's going to the sigmoid sinus and creating a venous fistula. Notice the venous veins are engorged on delayed imaging. Well, the reason is you've arterialized the venous side of the brain, so the venous pressure is high, and the normal brain venous drainage doesn't occur, at least not normal, at least not in a usual pressure pattern. This is after I embolized it with some onyx, and she went for microsurgery, and you can see this completely resolved, and her vision came back, was restored to normal. This is a 54-year-old with onset of headache 10 days prior to arrival. This is one of my first cases here at DMC. She was seen and evaluated elsewhere twice over that time frame. And she presented to the emergency department with signs and symptoms suggesting acute left hemispheric stroke. Her initial MRI shows patchy areas of cortical restricted diffusion consistent with infarcts, but they're not in a usual neuroanatomic distribution. In other words, they're not in a vascular pattern. While she was in the emergency department, she developed a gaze deviation right hemiparesis, actually after she was given some medicine for her headache. Her CAT scan is relatively unremarkable. Her MRI shows this patchy area of restricted diffusion out in the cortex, maybe even on the other side. So the constellation of acute hemiparesis and aphasia following a Dilaudid dose for cephalgia headache in the ED suggests she has some other process. So we deferred giving her intravenous TPA because it was clear this is a completely different kind of process and it had been going on for probably 10 days. Here's her initial arteriogram. I took her straight to angio. You can see there's severe vasospasm in the middle cerebral artery distally. These are normal vessels proximally that look like fat sausages. And on the lateral view, there's a large posterior communicating artery aneurysm, and from the neck of the aneurysm, there's a persistent fetal origin of the posterior cerebral artery. So her symptoms are all due to vasospasm, secondary to a subarachnoid hemorrhage from ruptured aneurysm 10 days previously. Here's the aneurysm on a three-dimensional reconstructed image. This is coil placement. You can see the aneurysm looks very well coiled. This is after embolization. Notice there's no flow in the aneurysm, and this vessel is still open. And now we've treated the vasospasm therapy. This is after I've treated her with intraarterial nicardipine. You can see this vessel starting to open up. And 6 months later, I've seen her back in clinic. She is now normal and completely recovered from the entire episode. This is her middle cerebral artery and candelabra. The coil mass is stable. So let's chat for a moment about subarachnoid hemorrhage. Management of hemorrhagic stroke is a significant public health issue. Occur approximately 30,000 cases a year in the U.S. It may be a little more than that at the moment. More than half of these, about 17,000, die as a result of the initial hemorrhage. 10% never make it to medical care. They die in the field before they ever reach a hospital. Up to 50% of survivors with significant permanent neurologic deficits, and 95% of fatal subarachnoid hemorrhage is secondary to aneurysm rupture. The most common cause of subarachnoid hemorrhage is trauma, but is often mild. The ISAT trial, International Subarachnoid Trial, tested neurosurgical clipping versus endovascular coiling, or actually, compared the two with over 2,000 patients. There have been several similar studies, much larger and subsequent, confirming the results of this. The trial had to be stopped due to a significant improved benefit from endovascular treatment rather than open craniotomy. This is a devastating disease. 25% die within 24 hours of onset, 10% never make the hospital, 45% die within 30 days. Only approximately 33% will have a good outcome. Prognosis of subarachnoid hemorrhage, although wildly variable, is dependent on a number of features, including the volume of initial hemorrhage, whether or not they rehemorrhage, which is often fatal, neurologic grade on admission, which I cannot stress enough, cannot be assessed in high-grade patients until after an EVD has been placed. Delayed causes, delayed cerebral ischemia and vasospasm are actually today as responsible for as many deaths as primary hemorrhage. Cardiac complications and pulmonary, particularly neurogenic pulmonary edema, are also significant contributors. So this is a much older case, done in an old single plane room. Here's my 18 millimeter dime. The middle cerebral artery shows a very tiny aneurysm right here at the bifurcation. This is a superior M2, inferior M2, anterior temporal branch out here. The aneurysm is just under 2 millimeters. So to give you some idea, this is the coil I used for that case, along with the sterile dime. And you'll notice that the 2 millimeter coil is about the size of the ear on a Roosevelt dime. Notice the wire that comes back. So I had to actually have the anesthesiologist give this patient Esmol to slow her heart rate down. I couldn't get in the aneurysm. I had to coil it from the middle cerebral artery and tuck this coil in. Notice as the coil is placed, there's no longer any contrast outlining the aneurysm. That's because it's thrombosed, so it can no longer bleed. Hunt and Hess grading system is a clinical, one of the clinical tools we utilize for assessing these patients, typically on admission. There are several other grading systems. The World Federation is common. This is the one that's used in most of the United States. So a grade 1 is asymptomatic with minimal headache or without neck rigidity. Grade 2 is a pretty bad headache, but and a stiff neck. You may have an isolated cranial nerve palsy, typically a third or ocular cranial nerve. A grade 3 patient is drowsy, confused with a focal deficit, Perhaps their left arm is weak. Grade 4 is stuporous, moderately severe deficit. They may even have decerebrate rigidity, and grade 5 is a deep coma and moribund. So this system was originally developed to evaluate the patient for timing of open craniotomy and surgery, and doesn't really apply to endovascular treatment very much. We still use it as a general overall contributor to, prognosis and what to expect from the patient when they are managed. Once again, that you cannot give a Hunt and Hess grade until an EVD has been placed if their grading scale is high. The Fisher-Kistler grading scale, or now the modified Fisher grading scale, is based on radiographic findings and quantitates the subarachnoid hemorrhage seen on CT scan. This scale is actually utilized for assessing their risk for cerebral vasospasm. So a grade 1 is less than a millimeter or no visualized blood. It can be focal or diffuse. A grade 2 is the same but with interventricular hemorrhage. A grade 3 is thick subarachnoid hemorrhage but no interventricular blood. And a grade 4 is a lot of blood with interventricular hemorrhage. So this is a 46-year-old that was transferred from an outside facility with severe sudden headache, fell from a ladder, polysubstance abuse, alcohol, methamphetamine. Fisher-Kistler grade 3, Hunt and Hess grade 2. He had a ruptured anterior communicating artery aneurysm. Notice, despite his young age, this extremely tortuous vessel, likely from the methamphetamine contributing. And there's a tiny ruptured anterior communicating artery aneurysm, very difficult to see. And you can see it's a little frosted. There may be some clot associated with it. It measures 1.2 by 1.4 millimeters. That's smaller than the one I just showed you. So this is a microcatheter access. I could only get a single 1x1 coil within the aneurysm. And immediately following a placement of the coil, you can see now that the entire anterior cerebral artery is thrombosed. Probably the clot and the frosted appearance you saw in the last image represents displaced clot after the coil went in to secure the aneurysm. There's also some component of hyperthrombosis due to the underlying methamphetamine. So now the aneurysm has a coil in it. We gave him intravenous integralin. This is 8 minutes after integralin injection. You can see the coil is here, and now there's some flow in the anterior cerebral artery. I was very concerned that the patient might have thrombosis elsewhere, and I couldn't evaluate the anterior circulation. So while this was waiting for the integralin to work, I gained access to the contralateral femoral artery, and this particular image was acquired by putting a catheter in the right internal carotid, the left internal carotid, injecting both at the same time and showing that all these vessels are in fact open, and the aneurysm is very hard to see in here, but it is thrombosed. So this is an older case. This is a patient that I saw actually in the CT scanner while he was getting a CT scan for a headache. As we brought him out of the scanner, he reached up and grabbed his head and fell back and blew his right pupil. We immediately rescanned him and brought him straight down to the arteriography suite. He was crashing, rapidly intubated. We put a catheter in, and the salient findings, here's the catheter in the internal carotid on the right. Remember, I've already seen the CT scan. There's contrast in the maxillary artery out to the face, but the internal carotid artery shows no flow. You are looking at an angiographic Cushing reflex, where his intracranial pressure has exceeded his arterial pressure, and there's no intracranial blood flow. So life is very short, a minute or two, a few minutes, because there's complete intracranial cerebrovascular arrest. So I stopped, dropped the catheter, shaved his head, put a ventriculostomy in. This is the first image after I got the EVD placed. Here you can see the catheter. It's not really easy to see superimposed over this MCA. But now there's flow back, and there's a middle cerebral artery aneurysm with a daughter cell. You can see contrast extravasating every single heartbeat. Here's the EVD. I raced up and put a microcatheter and coil the daughter cell. I couldn't get the main part of the aneurysm because I couldn't untangle all these branches emergently, but at least shut down the hemorrhage. And notice that there's now a crisp perfusion of the remainder of the brain. The EVD has functioned effectively. In fact, he lost 3 units of blood through this. We had to transfuse him for his blood loss while I was doing this. But despite the blood loss, the entire procedure time from puncture till the aneurysm was secured was less than 45 minutes. So here's his 14-month CT follow-up. This is the day that the aneurysm blew while he was in the scanner. This is actually a hyperacute hemorrhage here. It's not white yet. This is all blood in the right hemisphere. You'll look that his CT really hasn't changed very much. He walks with a cane, but is otherwise recovered quite nicely. I've tried to get him to return to have the rest of that aneurysm fixed, and he has decided he's done well enough and he's not ever going to come back. I still see him in clinic up until I left Hawaii a few years ago. This is a flight attendant who was on vacation, who collapsed at a hotel, brought in Hunt and Hess grade 3, Fisher grade 3. I love showing this case to my house staff. If you look at the sort of star-shaped pattern of blood, and then a little bit of hydrocephalus, the temporal tips are prominent. So where did the blood come from? Well, it could be an anterior cerebral artery, or a basilar tip, or a posterior cerebral artery, or a proximal M1, or it could be anywhere. There's no way to tell. So here's that patient's arteriogram, and on the right there is an anterior cerebral artery aneurysm that's about 7 millimeters, and on the left there's a middle cerebral artery aneurysm that's about 5 millimeters, and the basilar tip aneurysm, all of which are now coiled, which is about 7 millimeters. But as the crow flies, these 3 aneurysms are literally about 12 or 14 millimeters apart. And because I can't tell which one ruptured, you have to treat all 3, because if the one you don't treat bleeds, the mortality rate from a repeat subarachnoid hemorrhage from an aneurysm is well over 90%. The pipeline embolization device. So coils have been a mainstay for aneurysm therapy from an endovascular standpoint for decades. In late 2007, and then we developed and brought out the pipeline embolization device. This is the first issue, volume 1, issue 1 of the Journal of Neurointerventional Surgery. And this is now the staple for our Society of Neurointerventional Surgery. And you can see a pipeline device on the cover and contrast in an aneurysm. So this is the first pipeline case done at Doctors Medical Center in Modesto. It was a 59-year-old morbidly obese male. He had been diagnosed with severe Bell's palsy, left-sided ptosis, concomitant headache, and disorienting diplopia 18 months previously. In fact, he'd been to a number of different physicians to try to find out what was wrong with him, and he ultimately ended up under the care of UCSF Ophthalmology, and they were going to develop some custom lenses for his diplopia, but his headache never went away. He was admitted to the hospital with severe headache and malignant hypertension. The CT scan, the CT angiogram scan performed here, is not very impressive because it doesn't show you the terminal carotid, and it's clipped off on the cervical images. 3D reconstructed images show only a questionable abnormality in the siphon, but it's highly suspect. Look at the double globe artifact here of the eye because of the way it's processed. MRI shows an abnormal flow void with mixed signal in it in the carotid terminus on the left, but it's not very well characterized. So here's his arteriogram. So the internal carotid comes up to the cervical segment, and there's a large dysplastic, ugly aneurysm with a spiral tortuous segment before the siphon running up into the middle cerebral artery and carotid terminus. Here's a 3D mock-up of acquired in the neuroendovascular surgical suite, and you can see this is kind of a ear-shaped, wide-necked blowout aneurysm. This would be impossible to coil. Not only would it be impossible to coil, you've got a dysplastic artery which is abnormal. So we took very careful measurements and put him to sleep, measured the caliber of the vessels above and below the aneurysm. And I know this is a difficult slide to see. And see, this is the tip of the delivery system. There is a pipeline device right here that curves around and comes back on itself. Remember, this is incredibly tortuous. This actually took 2 pipelines. In deploying the second one, the carotid artery transiently occluded. We got it back open with some integral in a few minutes. What you're seeing here is what looks like an A1 segment occlusion. It's not. It's because the middle cerebral artery has been starved of blood for a few moments, and this is filling from the other side, and all the blood is preferentially going out the middle cerebral artery. This is the construct of the pipeline device. You can see the trapped contrast. Remember, he's laying with his head back. This is the occipital, and his nose is out here, so the fluid level within the aneurysm is gravity dependent. So here's this like 380 degree turn, S-shaped, and here he is. Here's the final run. So you can see the artery looks very different now. There's still some contrast in the aneurysm, but there's relatively normal appearing flow despite the tortuosity. When he emerged from anesthesia, his headache was resolved for the first time in 18 months. He no longer required IV therapy for his malignant hypertension. His diplopia resolved in about 2 weeks, and he no longer needed to see ophthalmology, and his vision went back to normal. This was all from pressure on the third nerve and optic nerve from the aneurysm itself. His follow-up angiogram 6 months later shows a completely normal blood vessel, widely patent. It looks like it was just made yesterday, and everything's open. Here's the pre, here's the post, a 3-dimensional construct. The future. It's so bright I gotta wear sunglasses. We're rapidly changing technology to include imaging chain devices and pharmacologics. We have just received a new MRI here at DMC, but we're in the process of upgrading and adding a 3T in the next year. New CT scanning is also in the works. I've been working on this for the last year, and it's still on the table and hopefully will be installed soon. Interventional MRI shows promises in other institutions. I don't foresee that in the extremely near future here. There is definitely increasing refinement of arteriography equipment and new pharmacologics, including new statins, antiplatelet therapy, antiplatelet drugs, and thrombolytics. We're likely moving to tenecteplase for IV TPA in our new protocol evolution in the next few months, and there are new rapidly evolving treatment protocols. Thank you very much. This is a view from my old home on the Big Island.